and they don't have to package the patient up, wheel them down the hall to the OR. It's already set up to be an OR, and they can open the patient up right there. So that's pretty cool, and something that we have available to us at Kettering. We also have a cath lab that's set up the same way for cardiothoracic stuff if we needed to. So case introduction. So this patient. This is definitely one of your patients. You may have heard of this one. Was it this shift? No? No, it was last shift actually, because I had people like texted me from other stations as they heard me talk about it.
Yeah, blue shift.
So this patient, 56-year-old male patient, struck in the head with a tree limb. One patient on scene when you all arrived. On scene with them, co-workers had helped the patient to the ground and covered up where there was a spot of bleeding on their head. Not really aware of how bad the injury was at first, so they were trying to maintain the patient. According to the EMS run sheet and what I had documented in the chart for the hospital, the patient was semi-combative. Not necessarily combative, just off-put by everything, trying to push people away, didn't know where they were at, that kind of stuff. So kind of hard to manage, and the co-workers were having an issue managing the patient per the run sheet. General impression though, when crews showed up on scene, no acute distress. Patient was just kind of acting concussed, so to speak, but no acute distress, no screaming really, just not with it completely. Level of consciousness, the patient actually was able to answer, and so were the co-workers, whether the patient lost consciousness or not. The patient did not lose consciousness. And when you see the injury, it's kind of surprising. There's a lot of, wow, that's crazy that that even panned out that way when you see the injury. The patient did not lose consciousness, according to bystanders and the patient. Airways open, so whenever I talk trauma, or anything you do, but specifically trauma, airway, breathing, circulation, right? All our trauma surgeons will tell you when they walk into room 13 and you have a trauma patient there, you know, they have their white coat flapping in the wind and, you know, oh, they have all the answers. All they're thinking is airway, breathing, circulation, and they will tell you that. Patient's crashing, sir. Okay, let's start at the top. Airway. What's the airway look like? Let's reevaluate the airway, but they have a tube placed. That's great. Did it back out? Is it too far? What do we got? So they will always start at the beginning and work their way through with their patient. Now granted, I don't want to downplay what they do. When you get to the circulation parts, they are able to open people up and do things way above and beyond what others can do. But that's how they're managing circulation. So they're always thinking airway, breathing, circulation. This patient, airway, open, patent. According to the run sheet, the patient was answering some questions, making some incomprehensible sentences and whatnot, but they were talking. So let's say this lecture goes south, you guys completely hate it, and you march me out in the bay, and you know, I know I've probably said this before, but you know, Rents just loses it and snaps my femur like a toothpick. How are you going to know my airway's patent? Ah! Right? You show up on a car accident. Somebody's boogered up in a car. You hear him screaming. Cool, check mark the box. Airway, breathing, good to go. So far. You want to keep reassessing that. So airway's pretty easy to assess initially. Flip the script. You show up on scene somewhere, you hear somebody screaming, but you hear gurgling. You know something's in that airway and might become a problem later down the road. So airway, first thing you can check mark off. If you show up on scene, somebody's talking to you, you know they're moving air, and you're good to go there. Breathing, their rate of breathing was a little bit fast, but normal depth. I will tell you right now, even I used to put the classes of hemorrhagic shock in a lot of these lectures, but a lot of the information of classes of hemorrhagic shock, including is their heart rate elevated, are they breathing fast, those kind of things. I'll tell you right now, if I got whacked in the head with a branch, or if I snapped my femur, or we're in a car accident, if I step on a Lego in my house, I'm pretty sure that I breathe quicker and my heart rate goes up a little bit because of pain. It's a natural reaction, right? So we're not going to hang our hat a lot on a lot of those vitals in the beginning. We'll talk a little bit more about hemorrhagic shock and what we're looking at when we look at vital signs. If you see changes in vital signs such as blood pressure, so you get that narrowing blood pressure, they're trying to meet themselves in the middle there, you're already kind of late in the game. They're either at class 3 or late class 2 hemorrhagic shock, so you need to get them into an OR pretty quick. So vital signs, you're going to see a lot of these patients were breathing quickly, their heart rate was elevated. Circulation, distal pulses, everything was good to go. Disability, they were listed as a GCS of 13 based on the confusion of the patient. Rapid trauma survey. Go back to when you were in school. You said you're getting ready to finish up EMT, right?
Or I just finished up.
You just finished up. Did you learn decap BTLS?
Yes.
Deformities, contusions, abrasions, puncture, penetration, burn, laceration, tenderness, swelling?
Yes.
Yeah, cool. Just checking. So, you're going to start at the head, work your way down. And that's exactly what you're going to do. Now, in school, they're going to teach you, okay, I'm going to press on your face and see if your orbits are all good, and did it right. Real quick. Okay, airway, good to go. They're screaming, talking to me. We're going to just check real quick. I don't see any outward appearances of anything bad. Work our way down. This individual, start at the top, boom. Active bleeding. You have active bleeding. This is morbid, but that's great in the trauma world. If you have open bleeding, you can point at it and go, holy crap, there's bleeding right there. I can do something to try and fix it. Safe to say? We have another case in here where you have flank bruising, you have referred pain. Can we use x-ray vision and laying of hands and things like that to figure out where that bleeding is? No, we don't have that option to us pre-hospital, and then there's not a lot we can do if we can identify that. We can give them just a little fluid bolus and get them as quick as we can to a trauma center. Active bleeding? Hey, I see a pool of blood. Wonder where it's coming from. Oh look, there's where it's coming from. I can now try and manage that. Boom. Open skull fracture, scalp laceration. Coworkers were holding, I believe some rags or something to that effect on the patient's head. Everything else was unremarkable. So getting whacked in the head with a large branch, what kind of things are you going to think about besides the wound you've discovered?
Neck injury.
Neck injury. So an axial loading type injury. You get a force that hits you directly on the head, it can easily cause any sort of burst fracture or displacement of the spinal cord. So they assessed that in the run sheet, which was awesome. No focal neural deficits. Everything was good to go from an assessment standpoint. I do not remember, I'm pretty sure they did, but I don't remember if they tried to put the patient in a C-collar or not. But per our protocol, this patient would at least get a C-collar, just in case, right? Because you have some LOC changes. He might not be able to identify, oh, my neck really hurts. So at least a C-collar, move them in line as long as you don't have focal neural deficits that are active that you can identify. So this, of course, onset was sudden. He got whacked in the head with a tree limb. He was, from what I understand, helping. They were cutting down a tree. He had a rope to kind of guide it, so when it cut loose, it swung, whacked him in the nugget. Pain, nothing noted to make it better or worse. Pain was listed as a 7 out of 10. Happened 20 minutes prior to arrival. I already talked about how the patient was semi-combative, kind of fighting off coworkers, just kind of incoherently moving his arms and feet around, kind of brushing people away. Past history was noted in the run sheet that the patient had COPD, and I'll say good on it. Patient was worked up for some of that too, just to make sure that there was no exacerbation or anything of that effect. Not the immediate life threat right there, but at least it was touched on to make sure that wasn't going to make things even worse for the crew while they're inbound to Kettering. Vital signs. Pulse, 137. What did I say about vital signs? Is that elevated? Yeah, right? If I got whacked in the head, I'm sure my vital signs would be up too. Respiratory rate, elevated-ish. They kind of say the 12 to 20 kind of range, or 12 to 25, just depends on what you read. Blood pressure, anything wrong with that? Nah, not right now. That's probably better than my blood pressure right now. Depends on how much coffee I've had, but we also don't know what kind of meds he's on, and he wasn't able to describe that to us. So there might be something underlying there where compensatory mechanisms have been shut off because he's on antihypertensives. Pulse ox, good to go. Now head injury, and National Registry now lists it for stroke and whatnot. High flow O2s, no. Oxygen-free radicals and all that fun stuff. We're not going to go down that pathway. So keeping them at or around 94 is what our protocol says for a lot of this stuff. Reason for that, 2% margin of error in a pulse ox. So give or take 2%, so that's going to keep you floating above 90. So 96 isn't bad. You could probably throw some supplemental oxygen on the patient, especially with a head injury. You're going to still just want to throw nasal cannula on, give them a couple liters, help them out some, make sure everything's oxygenating the way it needs to. 4 lead had sinus rhythm listed. So what do we think we have going on with this guy? He done got hit in the head, right? Anyway.
Medic 45 and 45, so get ready to repair going. So
Easiest rescue.
93 when you're going. Don't forget. Medic 45.
Standing level fall, anticoagulants.
But it's all over the half year. It is a lot.
Cool. Moving on. Treatment indicated, we already kind of got ahead of ourselves and discussed that. So some level of spinal precaution, at least C-collar, just because of the way the injury occurred. Transport considerations. Why do we want to go to a trauma center with this patient?
Is it an injury?
Because there's an injury, yeah. So, better question. What level of trauma do you want? 1, 2, or 3?
Surgical.
You want somewhere that has surgery, right? Specifically somewhere that has neurosurgery. 1 and 2 afford that. Level 3 depends on how they're set up, but they don't have to have it. So just keep that in mind. We have 3 level 3s in our network. So I will freely say that straight in front of them. They know it, we know it. ACS does not require them to have neurosurgery on hand 24/7. 1s and 2s have that capability. So making sure they get somewhere, especially when you see the injury, you're going to be like, oh crap, they're going to need a neurosurgeon. You're going to know to take them to a 1 or 2. So something else that was noted in the run sheet, the branch that struck the gentleman in the head had noted bone fragments stuck to it. So you knew you had an open skull fracture. This was an open skull fracture, or as was listed in the chart, an opening of the vault, so to speak, because it actually impinged into the brain cavity. So you have the immediate area of insult right there. You have fragments, and then you also have, yesterday I had to use the mouse because people were online. You also see the fracture kind of makes its way down here, right? Keep that in mind when I show you another picture of when we talk about some arterial structures. He got very lucky. So, open skull fracture here, fractures that continue their way down. This guy's having a bad day. There's another image for you to give you an idea. So, remember I was kind of alluding to arterial structures right there?
Push out of the way.
Middle meningeal artery, those kind of things run right there. Missed all of it. So he didn't have any active bleeding from that standpoint. He did have a huge hematoma though, because he split his scalp, busted his skull. There's your CAT scan. Remember a CAT scan where somebody goes through the big donut there and it's taking slices, pictures slice by slice. So I have access, it was actually another question that came up yesterday. I have access in Epic, if I was able to pull it up here. I can take that picture and I can actually rotate it and twist it and do all this fun stuff. So I picked the best images I could that would show up on the PowerPoints. With CAT scan, as I scroll the mouse, it'll actually start from the top of the head and work its way through every single slice of the image. So this is one of the best images I could put on the lecture for you. So you see, you have your hematoma right here, right? So that's outside, so that's all scalp and whatnot, soft tissue bleeding and all that. There's your impingement into the skull cavity there. So that's the break. You can also see there's slight swelling to the brain. How do we know that from just looking at this and not being...
There's no black around the bottom of the edges.
No black around the edges. And there is a slight shift. So you see the little butterflies, not all pretty and good to go. That's your ventricles right there. Shifted slightly. You also don't see your little black wrinkles all the way around the edges there, which is what you should see. And the older the patient, the more you're going to see it because brain size shrinks. So he did have some swelling going on when this image was taken. You can see the hematoma where it's at. So case developments. My understanding is the patient, as they were inbound to Kettering, did stop breathing. The crew ventilated the patient, and they began to breathe on their own by the time they got to Kettering Medical Center, but he did stop breathing en route, but was able to start breathing again. Of course, once they hit our doors, and don't ever take offense to this, when they hit our doors, trauma patients, even if the airway was pretty decent in the beginning, like for you guys from a management standpoint, they hit our doors, 9 times out of 10, they're going to get sedated and intubated. Reason for that, especially this fellow right here, if he came in talking, due to the severity of the injury, they're going to check mark and make sure they secure airway straight out the gate so that they don't hopefully have to worry about it through the rest of their assessment. And they know this patient's going to have to go to the OR, so let's just sedate them, intubate them, and move on. So they'll assess the patient. Sometimes when you drop folks off, by the time you're getting out of there, you might see them tubing them. It's not something that, maybe not something you had to do pre-hospital, but it's something that we're going to do to definitively secure that airway. Cool, we got it. We know we got it. And if we know there's issues, we know how to manage it because we have the airway secured. That's what happened with him, of course. They sedated him, intubated him after they assessed him. Neurosurgery came down and evaluated him. He was taken to the OR. The patient ended up getting a craniotomy for evacuation and reduced some of the swelling there. They cleaned up the skull fracture, so when they did that, when they do a cranie, they of course cut a section out of your skull, so they kind of cleaned up the wound, so to speak, so it's not all jagged. They had to wash out and debride it, make sure that there was none of the shards of skull in there. And of course, you had something from the outside world enter the body. So they had to make sure everything was flushed out, cleaned out, and good to go. Anybody that ends up with open fractures of any type or stab wounds or something has impaled somebody, or in this gentleman's case, branch opens up the skull, they immediately get antibiotics. We have a whole protocol for that, for any sort of opening of the body to the outside world, if that makes sense. So immediate prophylactic antibiotics for these patients. Duroplasty, the patient got a duroplasty. What that is you have the dura. Remember from my stroke lecture that I did not too long ago, it's the protective covering around the brain. The dura mater, tough mother, is what it means. It is, if you've ever done a pig lab, it's very similar to the pericardium. If you've messed with it on a pig heart or any sort of anatomy lab, it doesn't have a lot of give to it. It's relatively thick. It's very tough. This patient, of course, had some issue with that it had ruptured it, so they performed a duroplasty, where they open it up, and this is one of those things fun you can look on YouTube later. There's different ways they can do it. They'll open it up, remove the damaged part, just like with the skull, and then put a patch on there. There's many different types of things they can use for a patch. They have synthetically grown material. Tissue banks have things that they can call in. They can actually use part of the patient's own pericardium, so a lot of different things. The run sheet, or I'm sorry, the report did not describe as to what they used, but he ended up with a duroplasty because there was some damage to the dura. And then drain placements, of course, for recovery, because you're going to have excess fluid that will subside over time. So drain placements directly out of the skull to make sure that it's draining off any fluid and not collecting and causing more issue. So field impression, we know that already. Open skull fracture, the run sheet described it perfectly. I mean, I felt like I was there. Great narrative, was able to get a lot of description out of it and see what was going on with the patient. Treatment indicated, we already kind of got ahead of ourselves. Some level of spinal motion restriction, which was taken care of. I believe there was a C-collar placed. Airway management, which we described what happened on the way to the hospital. IV at a keep open rate. So for this patient, you're going to want to get that IV and spike a bag, maybe just have it hanging, but you're not going to want to just dump fluid into them. But just in case you have it ready to rock and roll, in case the patient goes into some level of arrest, you're able to push meds and do all that fun stuff. So don't discount getting that IV in these patients. Transport considerations, we already discussed why you would want them to go to somewhere with neurosurgery, of course. So the cranie, this is just to give you an example of what a cranie looks like. This is to evacuate a hematoma that's subdural, so below the dura. So that's exactly what you're looking at right there. So they'll identify where they need to do this, which is what they did with this patient. They open up the area, they'll remove the skull, they'll cut open the dura, and if there's a bleed, they'll get rid of the hematoma and then cauterize the bleed. With this patient, that's pretty much what they did with this, and then they put Humpty Dumpty back together again. So put the bone flap back if it's something that's solid. In the case of him, since he had breakage and whatnot, they had lots of plates and whatnot they put in. It's not like what you think, like Christmas Vacation, Cousin Eddie, you know, tapping on a plate. It's more of a daisy chain looking type material that they placed everywhere, including that fracture that ran down the temporal area there. So there was a lot of those little pieces, parts to kind of shore everything up and get it back together so that it can heal. We already talked about that stuff. We talked about the different hemorrhages. So back to what I was discussing. Remember the arterial structures we talked about? Guy got lucky. So his fracture was probably right around in here and rolled right down here. So if he had been hit somewhere else, more in the temporal region, he could have been in a bad way. He could have had a severe arterial bleed from the middle meningeal artery. And that's why if you ever hear of somebody that takes a line drive to the temple, that kind of stuff, that's why it's so concerning, because you have a arterial structure that's very close to the surface that can be injured very easily. We talked about all these last time. Questions about this one? Is anybody on this one? I know it was another shift, but you guys worked different stuff. Yeah, the thing that was very descriptive in the run report was the bone fragment on the limb. That was, it was like, oh, that's interesting. Okay. Okay. Case number 2. This is not one of yours, but again, well-rounded trauma training. We want to make sure we touch on some of this information. So, MVC, 21-year-old male patient, unrestrained driver. First things we should be thinking of, unrestrained driver. You're going to want to do your homework, right? You show up, you're going to want to really get an idea of the inside of this passenger compartment. Where's the patient at in relation to what they were doing? Were they driving? Were they passenger? Where are they at now compared to that? And then identifying different things. And then we go back to the basics, right? Looking for starring of the windshield, any sort of bending or disruption to the steering wheel, looking for blood in correlation to whatever wounds they may have within the compartment of the vehicle, A post, B post, those kind of things. So all stuff we need to try and do when we show up. I know everybody does a great job of this, but always like to remind, you show up on scene to a nasty car accident, sometimes that tunnel vision sets in. This is one of those cases you want to take a step back and just kind of get the whole picture and really do your kind of investigative work to make sure you're treating the patient based off of injuries. Because this is the type of patient right here that's not going to have potentially active bleeding that you can point and go, I can fix that. This is the one that's going to be complicated. So identifying where they possibly rattled around in there like a pinball, what they hit. Motor vehicle accident, 55 miles per hour into a pole. Number of patients 1, witnesses on scene. Oops, yep. Unrestrained. Where's that pole sitting?
Where the driver.
Where are the drivers, right? So we got one patient, we know they were driving, that's a bad day. So we got some concerns with the unrestrained. Level of consciousness, patient was alert but is amnesic to events. Airways open, patent. Breathing rate 14, pulse ox 97, circulation heart rate was 108, skin pale, cool, and dry. GCS was listed as a 12, pupils equal and reactive. So amnesic to events. Not always the case, but again, we have no way of scanning them in the back of this vehicle or in the back of our medic. What is amnesic to events probably going to kind of pique your spidey sense on? Head trauma, right? They whacked their nugget. Now how bad they did it, we don't know yet. So amnesic to events, yes, they possibly whacked their head somewhere in this whole mess. Rapid trauma survey, multiple abrasions to the head, neck, no trauma, chest, contusions to the right chest, abdominal, abdomen, tender in all quadrants. So now what are we worried about? Internal bleeding. Again, external bleeding, again, it sounds morbid, but hey, I found it. I see the pool of blood. I know where the bleeding is coming from. I can try and fix that. Internal bleeding is going to be one of our biggest enemies in trauma, because there's not a whole lot, if it nothing, you can do except for a diesel bolus to somewhere with an OR. We can get fluids on board, but we can only do so much with that just to make sure we're not blowing out soft clots and going down that pathway. There's just not a lot we can do for these patients except get them somewhere quickly. So we're worried about internal bleeding on this patient. Extremity abrasions to the extremity. On the back, there's left scapular pain. Does anybody know what that might be indicative of? This is one of those kind of obscure things that you learn at some point and kind of forget.
Spleen injury?
Very good. Strong words. So yes, you can have referred pain to different areas. And I'm not saying you got to remember all of it, but you can have referred pain to different areas, and it could be indicative of injury to internal organs. Now, what's your name?
Sierra.
Sierra. You have identified that this is the spleen. What are you going to do about it on scene?
Note it.
Note it, do nothing, right? Yeah. That's why we usually forget this stuff, which is fine. But so if you completely forget that the left scapular pain is indicative of a splenic injury, that's cool if you remember it, and that's great. But if you can remember that referred pain to either of the shoulders means something here is busted up, making sure you paint that picture for the hospital. Because then they're going to know, oh, spin up the OR. I possibly have a splenic injury. Or the opposite side can be indicative of liver injury, that kind of stuff. So that'll take them down a pathway, takes a lot of the guesswork out for the hospital and some of the imaging. Sudden, of course, diffuse cramping pain, referred pain in the shoulder, we already talked about. Vital signs, pulse 108, we already talked about respirators haven't changed. Pulse ox now diminished. So with what we've talked about internal injury-wise, we're concerned about possibly dropped a lung, right? We're going to reassess airway, see if we have to go down the pathway of needle decompressing them.
Press that side.
Yeah, stick them. Stay good. As long as they're hemodynamically unstable, per protocol.
Can't you get it?
Or at least note that, you're lucky. And I will say, our trauma surgeons, follow protocol to the way it's spelled out for needle decompression. But our trauma surgeons will tell you, they'll put a chest tube in they'll bilaterally give a patient chest tubes if they think they have any sort of thoracic injury, whether or not they have a dropped lung. It's procedure because most likely they do. Most likely they have bleeding in that area. They're going to need it anyway, that kind of stuff. One of our trauma surgeons always likes to say, and I have to say, no, that's not what protocol says, but he has a good point. If you needle decompress them and you were wrong, what have you done?
Put a hole in.
Created a new hole and also the resolution to that hole you put there. So, okay, whatever. No big deal. So don't second guess yourself. If they're hemodynamically unstable, you think that's what they need, do it. So we've already kind of got ahead of ourselves. We're thinking internal injuries. This person's in a bad way and could easily dive right over the cliff and be bad news for us. So we got to get them somewhere quick. Transport considerations, I'm not going to go through that. Radiology. So things that they'll do once they hit the trauma bay. In the trauma bay, they can do a fast exam. So they can get the ultrasound out, and there's a way of placing the probe in certain places without getting too technical and determining if there's free-floating fluid. Now, that fast exam is only good for certain spots because the patient's laying flat. If you have free-floating fluid in the abdomen, where's it going to go? Gravity, right? Might make its way to the backside. You might have injury somewhere else. So that's going to be step one for them. Okay, let's do it fast. If they have a positive fast, we're going to the OR. Because you've identified it right there and then, we're going to the OR, there's internal bleeding. If they don't see anything on the fast, but still have signs and symptoms of some sort of internal hemorrhage and they can't identify where the hemorrhage is, then they'll take them to the scanner and they'll pan scan them, do a chest, abdomen, just trying to see what they have. And that's what you're looking at here. Again, CAT scan slices, right? This is, now we're into the body, not just the head. So you have anywhere dark is going to, anywhere dark is going to be your free-floating fluid. And I say free-floating fluid because it's not always blood, but it's most likely blood, so they always document it as free-floating fluid. So there you go. He's got fluid in it, right? He's boogered up. And he needs to be opened up and fixed somehow. Or taken to IR and embolized. So interventional radiology, they can sometimes do this stuff without opening them up, depending on where they're bleeding. So the CT showed abdominal bleed. Patient was taken to the OR emergently. Patient was found to have a grade 5 splenic laceration. Strong work. You went, oh, the spleen is broken. You use the force, right? So splenic lacerations 1 through 5, 5 being the worst. I don't believe there's a 6, but 5 is pretty bad, okay? 5, your spleen is cracked in half, it's obliterated, it's donezo, it needs taken out, if not all of it, at least part of it. And that's what this individual needed to have happen. All of our spleen, liver, those organs have large arterial structures connected to them. So this is why it's such an issue when they get injured, because you're going to end up bleeding a lot from those organ structures. My wife actually, when we first met, well not when we first met, when we first started dating, she fell asleep at the wheel and totaled her car into a telephone pole. And she had a car that had the old school remote control strap thing, right? You know, they don't do it anymore because of this. She never put her lap belt on. So she had the shoulder strap on, hit the telephone pole, slid forward. Again, looking at the inside of your vehicle, the steering wheel was bent because she slid into it. The steering wheel caught her here, lacerated her liver. She almost died from that. Her imaging is actually pretty interesting because it was an itty bitty little laceration that they went in interventional radiology and coiled it. Good to go. But just that little itty bitty laceration in the right spot, she almost bled out. So, these injuries are serious. Sports med, when they come out and talk to you about this stuff, that referred pain, splenic injuries, getting clipped on the football field, there's folks, young folks that get nasty splenic injuries from football pretty easily. Soccer, I've heard of those also, where they had pretty nasty splenic lacerations from soccer injuries. Patient also had a left pneumothorax, left lung contusion, all because of a couple rib fractures that they also had, and a small bowel injury. So your anatomy of the abdomen. So they had a small bowel injury, so right up in here, right? So unrestrained, most likely hit the steering wheel. That's probably what caused that. You had your spleen, which sits right here, and you had some rib fractures, and you had some tenderness and so on and so forth. Rib easily can bust off and puncture any of these things. So that's why we're always concerned with rib fractures and where the injuries might be. Where's the rib cage in proximity to where the injuries are and the bruising and so on and so forth. Kidneys sit a little bit lower. But that's what we're looking at, and that's what we're concerned about if we have any sort of abdominal or thoracic trauma that we know of. Splenic injury, we already talked about, referred left posterior shoulder pain. Liver injury, it's the opposite side, right posterior shoulder pain. Severe hemorrhage, you're going to again have if you're emptying out your blood volume into your thoracic cavity, your abdomen, your pelvis, you're going to have distension, tenderness, tenseness. From the pelvis, bony crepitation. Remember, when you're testing the pelvis, push down and in. Don't do this number, and don't move it around a whole lot, because if it's busted up, you're going to cause more harm than good. Seatbelt signs usually don't appear early. Issues with seatbelt placement. If this patient was restrained, was the seatbelt in the right spot? Seatbelt needs to be over the pelvis, near the iliac crests there to kind of hold everything, because it's a nice sturdy structure. When you get it too high, that's going to stop you. So 55 miles per hour, this individual, 55 miles per hour is now going to translate, and whatever's going to stop you, 55 miles per hour is now, all that force has been inflicted on internal organs in that region. This is why it's very important that kids are in proper seating situations, like car seats, boosters, stuff like that, because the seat belts are designed for adult anatomy. Kids, they're going to sit right up here. There's cases out there where adults and children, seat belt placed wrong, high speed impact, the body just folds around that seat belt, can also shear the spinal cord and cause those kind of injuries to the patient. So if you see that the seat belt's placed above where it should be, those are things you should keep in mind. Might have spinal cord injury, most likely will have internal bleeding, so on and so forth. Questions on that one? Cool. Chief complaints, hip pain, 34-year-old male. Seen auto shop, patient was a mechanic, walked behind a car as his buddy was pulling in a vehicle. His buddy ended up pinning him between a brick wall and the vehicle. I'm sure they're not friends anymore. Number of patients, 1, bystanders, the co-worker called 911. Crews show up on scene, patient's lying on the floor in obvious distress and pain. Level of consciousness, he's alert. So again, go back to, okay, cool, he's screaming. That means his airway's paving. We're good there. We can check that box. Breathing rate 14, pulse ox 95, circulation heart rate elevated, of course. He just got crushed by a car, so that may or may not be indicative of some sort of hemorrhagic class of hemorrhagic shock. But he might just be elevated because he's in a lot of pain. Disability GCS was 15. Rapid survey, head, neck, chest, no trauma, abdomen, tender and lower quadrants, contusions noted bilaterally. This is why it's important that we strip and flip our patients depending on where they're injured. Pelvis area, painful, bleeding from the scrotum. So where that vehicle hit him is dead on in his pelvic region. And this is why if you had that kind of presentation, okay, we got to get the pants off. Many reasons for that. Male, female, whatever. There's predetermined exit points on the body, okay? You injure internal structures of those exit points and start bleeding, you can easily identify bleeding from the rectum, any of those already predetermined spots. Other things to keep in mind with that also, if you have internal injury on the males, if anything's busted up and not causing any sort of blockage to a pathway to it, the scrotum can fill up with a lot of stuff. It can fill up with a lot of blood. It can fill up with a lot of organ tissue. There's cases I've seen where bowel has actually made its way into the scrotum and just filled it up with bowel. So lots of things that we need to be looking for when you have abdominal and pelvic injuries. Make sure you're getting the clothes off. Sharp stabbing pain, yes. Okay. Sudden, of course, abdominal pelvic pain. We've already stripped the patient, identified some areas of injury. Vital signs, pulse elevated. BP, what are we worried about with that blood pressure there?
It says he's on blood pressure medications too, though.
So he's on BP meds. So good thing to note to make sure why. Why is that a good thing to know?
He's going to have a little bit lower pressure as it is.
Compensatory mechanism to shut off. He's on medication to keep him at a baseline, and now anything that would allow him to go into shock and compensate, out the window. It's being thwarted by the meds. So, good call. We're not going to hang our hat on that BP. Pulse ox 95. They got a glucose on him. Great. Sinus tachycardia. Oops. There's your pelvis.
Destroyed.
Obliterated, yes. There's a lot of different ways you can bust your pelvis up. Of course, this was a load direct on that's going to bust it up that way. You can also, we'll go through this and then I'll talk about that. Complex open book pelvic fracture. Retroperitoneal hemorrhage. Retroperitoneal, the peritoneum is the covering inside the abdomen. And you can actually look for something called a Turner sign, where if you have anything from below the ribs down that you have bruising, that's called Turner sign because you have internal hemorrhaging below the retroperitoneal cavity there. Class 3 hemorrhagic shock, which again, he was on BP meds, so based on numbers, we weren't going to be able to really hash that one out right away. But we could kind of get an idea that, hey, he's bleeding, we know that. Bladder rupture, scrotal degloving with left testicular crush injury. That's a bad day. Bladder rupture. Something interesting to note for the bladder rupture, this is a fun fact and tip from Ryan. If any of you have even a decent drive home after a shift's over, make sure you pee before you leave. I will tell you, we see a lot of trauma that the car accident was pretty nasty, but the only injury they had is their bladder popped like a balloon because they didn't pee before they left wherever they were going. And it was full, and when the seatbelt got it, it just went. Then they end up in the hospital because they have a ruptured bladder. Fun fact, you're welcome for me to use. Treatment, stabilization of pelvis, we'll talk about that in a little bit. IV fluid to maintain peripheral pulses. So anybody that's done this for any decent amount of time probably remembers the 2 large bore IV pressure bag infused saline fluid on somebody that's a nasty trauma, right? We all killed a lot of people doing that. We were all reaching for a goal of a blood pressure. They'd roll into the trauma bay, hey, I got a great blood pressure. Chest tubes would go in and it's a light pink fluid. The blood pressure was just being sustained by a substance that is acidotic, a substance that does not carry oxygen and doesn't have clotting factors, which is safe. So what's been changed now is permissive hypotension. These patients, you just want to maintain peripheral pulses, make sure that heart and brain are being perfused, and that is our goal. We jack blood pressure up. Let's just take this fella, for instance. He might still be bleeding internally, but his body, due to just fight for space, it might tamponade off some bleeding, some clotting might already start to occur, so some soft clots might develop. That kind of stuff might already be in the works, and we jack the blood pressure up, we're going to kink that whole works up. We're going to blow out the clots, we're going to push whatever tamponade blood out of the way, we're going to help them bleed more, basically. So that's why we practice permissive hypotension. So the pelvis. This guy had a complex pelvic fracture. What we're looking at when we have a disruption of the pelvis is a disruption of the pelvic ring. So right here. You have your iliac, your sacroiliac joints right up here, which are a quote-unquote joint. It's a semi-flexible area. It's not like an elbow or a knee, but it can move somewhat. If you have a break anywhere down here that disrupts the pelvic ring and then opens it up, you can then have secondary breakage where the sacroiliac joint is, because it'll push it past its limit and then you can have breakage in that area. A lot of different ways your pelvis can break. There's no definitives, of course, in medicine, so whatever injury pattern or whatnot can happen, but some of the ones that are common, the subpubic angle, it can break right in this area. You can have cases, especially in car accidents, even restrained folks, that their leg either gets jarred by the floorboard if it crumples up, knee hits dashboard, can push the femur up into the acetabulum, which is basically the socket area where your femur places in, and actually bust and shear the pelvic ring that way. You can have different types of forces that come in from the side. So case in point, somebody with a vehicle hits you sideways, can break right here. So there's a lot of different places you can bust the pelvis up. The interesting thing is, so I already did gloom and doom about internal injuries and we can do nothing. Hey, great, we identified the spleen, but drive faster, that kind of stuff. This we can do something with. You guys carry SAM splints, my understanding, or SAM sling, I'm sorry. Great, you have a commercial grade pelvic binder, which is awesome. Use of a pelvic binder is going to do a lot of things for you. It's going to compress that area, tamponade things off. So yes, they may still bleed a little bit, but eventually it'll tamponade. You get that nice and tight. It's going to stop whatever bleeding you have in that pelvic region. A lot of internal bleeding we worry about is arterial. The pelvis, and I keep meaning to put it in this lecture, I have it in another one. There's a great image I have of all the vasculature in the pelvic region. Yes, there's arteries there, but you have a ton of vasculature there. And when you bust up that area, you're shearing a bunch of vessels. And when they hit our doors, they'll open them up. You'd think they go in and cross-clamp and cauterize and suture. It's just so vast, all the vessels that are there. They actually will open patients up, pack, close them back up, sometimes put the pelvic binder back on, and then continue to resuscitate them with blood and make sure that they're stable enough to go back and have that orthopedically fixed. So this is something great that we can do pre-hospital. Probably the thing we do most incorrectly with it is either use a sheet, which better than nothing, I guess, but we can't get it tight enough unless you have some sort of windlass there. You know, I know there's some buff folks, but as tight as you pull it, you're going to want it tighter. So get something as a windlass if you have to use a sheet. Placement's another thing that we don't do correctly. Placement of a pelvic binder. I have a break right here, okay? Pelvis is starting to open up. Every centimeter it opens up, the more bleeding that can occur, the more hemorrhage that can occur, the more blood loss there is. So we want to make sure we close it up, right? We've identified it, we know we can do something with it. Where do we want to place that pelvic binder?
Right over it,
Where now?
just above that, yeah.
So breaks here, you're saying a little bit above it?
Mhm.
So you're going to want to go,
Below the-
that's symmetry, yep. Do what?
Below the crest.
Below the crest, that's the big thing. You want to go below the crest because they sit like this, right? Even the pictures right there where they have the sheet, that's a little high. You get up here, you have the break down there, you start cranking on it, and you're pulling the crests like this, right? Specifically, it'll say the greater trochanters, which is your femur, right there, so you're going to want to go right about here. And crank all that down, and keep all that nice and compact. Something that I recommend, just because you go to all that hard work of making sure that that SAM sling is good to go and all tight and ready to rock, you're still going to have to move the patient, right? Try and secure the legs together if you can. Because you start to move them, well, what did I just say is connected to your pelvis? Your pelvis is busted, your femurs are up in there, and your legs are doing this number, right? You're messing up all the works. Keep the legs secured so that they're not wobbling all around and causing issue. Just think of it like splinting, right? You want to splint above and below, different joints, same kind of thing. Your legs are pretty large. It doesn't take a lot of movement that's going to mess up the kind of work you did there. Different types of splints, different types of pelvic binders that are out there. You guys have the SAM. Has anybody messed with it before? If you haven't, are they packaged or are they in plastic or anything? So they can get them out and mess with them. Go look at it because these all function a little bit differently. We have annual trainings, competencies on the teapot that we keep in our trauma bays because, I mean, it looks kind of complicated out the gate if you don't know how to use it, and it's fairly simple. Just get your hands on it. You don't want to be trying to bumble through it when you're on scene or on the side of the road. The SAM is pretty easy. It's got a spring-loaded mechanism with 2 prongs in it. You place it correctly and just start to cinch it down. Prongs will release. It'll ratchet where it needs to go, and then it has a Velcro backup. The T-pod, you can place, it's a big flap, that orange part on the back, and then the white part is 2 big Velcro pads with the cordage between it. You set it to whatever size patient you have. You can cut the excess off, slap the Velcro, you pull that thing, and all the cordage is wound in there as such that it makes it real easy to pull everything together. Then you have 2 pegs, you wind it around, and then slap this last little thing in his hand down. It's Velcro also. So pretty simplistic, but know your equipment, get it out, look at it, know how to use it so that you know what to do with it when you need to. Questions on any of that? Roger that. This is an editing issue on my part. This is not a hip pain, sorry. 78-year-old male patient. This is a scene of a parking lot, self-inflicted GSW to the head. Number of patients 1. There were bystanders on scene. My understanding this was a car dealership?
Yeah.
Car dealership.
Bob Ross.
Bob Ross, there we go. Patient was lying on the ground in obvious distress, but was verbalizing, yes. The run sheet stated it. We also had the same verbiage in our trauma bay, let me die, let me die. But, going back to what we said, though the area that is impacted is definitely going to be airway involved, he's verbalizing something, right?
Kind of,
Was there gurgling?
yeah. Oh, yeah, lots of.
So you knew there was airway that was compromised and there was issues there.
Yeah, lots of suction.
Lots of suctioning, which was well documented. So first thing out the gate when you show up, first off, scene safety. The run sheet documented where the firearm was and it was secured, so great on that. You know, you showed up on scene. We now know that the threat of any more harm is out of the picture. And you immediately jumped to airway. Great, airway breathing circulation. You knew you had to secure the airway because of where the injury was. Airway was open, patent, but blood present, obviously. Breathing rate was listed as a 20. A lot of the vital signs, and again, not a problem at all because it was documented as such. A lot of the vital signs were unable to be obtained due to the amount of blood. Pulse ox was listed, unable to attain because of amount of blood on the patient. I'm cool with that. You know, if you can't get it, you know the patient needs to be maintained from an airway breathing circulation standpoint, and you're already inbound to a hospital, okay, just document why you couldn't get it. So that's fine. Circulation heart rate 120, skin pale, normal, dry. GCS was listed as a 15. Of course, obvious open facial wounds. Nothing else noted anywhere else. That's not true. Sorry, that's an editing issue on my part. So, field impression. Airway, 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 right? And it was well documented as such in the run sheet. You guys knew it, and it was managed appropriately, at least from the standpoint that the picture I could paint from your run sheet. Lots of suctioning. I mean, that was darn near spelled out in the run sheet. Suction, suction, continual suctioning.
Any impingement into, I'm sorry.
Go ahead.
Any impingement into the sinus cranial cavity with the shotgun blast, or did it all pretty much exit out the front of his face like it looked like?
I will show you.
Because he flinched, which is good, otherwise he probably would have.
So I will, I have some imaging. Just
Okay.
the best image I could get to kind of get the point across with it. So airway was managed excellently. I know the first thing I thought of actually is when I've been out here and other places before, I have an airway lecture that has the fella that is a self-inflicted gunshot wound. It's a picture that floats around the internet, and he's sitting in the hospital, and I always ask the question, what's going on with this patient? Well, he's in the hospital. Well, why is he intubated? Because he's maintaining his own airway with a little bit of help from you all suctioning. Run sheet painted the picture that he was sat up in a position to drain things off. You guys were suctioning. You did everything the way it should have been done.
Digital innovation.
So,
Oh, barely. Wow.
yeah. He did lose an eye.
Yeah. That was.
So imaging wise, like I said in Epic, I can take this and I can turn it and spin it, but when you turn and spin it, this all went away. It actually showed further back. So this is the best image I could get for you of this. But this is your patient right here. Per the run sheet, you guys attempted intubation.
Digital innovation.
Digital innovation.
He had, it was such a good airway that
Yeah.
it's got stopped, yeah.
Yeah, because he had like a gag reflex or something.
Yeah,
like
he
that.
still had gag reflex,
Yep.
tongue was still trying to work what was left of it.
Because he was talking in the trauma bay, is what we had noted. So,
It wasn't until we were there on the way to the hospital and he stopped that we had to stick finger down, find a hole and stick the tube in.
yep. Which again was well documented. Did he also
At that point,
lose consciousness? He's sternal rubbing.
Yep.
Yeah,
Yep.
I'm getting this one mixed up with another one,
But, and one thing you gotta remember, I think we remember with this one was there's no there's no facial features.
Yep.
So we write, I think we realized we write stendum later because there's nothing to, no landmarks to figure out how deep we are.
That is true. The airway, it didn't specifically go into that it was right main stem, but they did adjust the airway in the trauma bay because they realized, and of course when you move them over, all that crap too, that it would jostle the airway from where it was. But if you right main stem them and in this kind of situation, you're still oxygenating at least 1 lung. So there's good bad on that one. Nothing I saw in this, could have been done any better. I think it went great. You managed the airway. Like I said, that scenario that I have in my airway lecture, I was watching it play out in your run sheet. So it was awesome. So what happened with this fellow? Open reduction internal fixation of the mandibular fractures. So you saw right here was fractured and part of it was gone. Reconstruction, a lot of reconstruction. He's still going through surgeries today. Left zygomatic complex fracture with evisceration of the left lobe. So that's going to be this area right here. Was busted up really well, and then that's the eye he lost. Trach and peg, any patient that comes in as a trauma patient, if they're intubated for any longer than they have to be, there can actually become tracheal breakdown. So what they'll do is they'll trach the patient. So you'll always see stories on the news or whatnot of somebody that was a really nasty trauma and was laid up for a long time, might have the trach healed over. That's why they do that, is because of the tissue breakdown in the trachea. They don't want to mess with that for a long time. So the patient was trached, pegged, so got a peg tube for feeding and nutrition purposes, because of course this was all going to take a lot to manage. Cheek and nose reconstruction with plastics. Treatment indicated, like I already said, great job, aggressive airway management, got them to the hospital. And you got them to a trauma center, of course, which is where this person needed to be. There's an example of your zygomatic complex fracture. So that's what that's describing. So,
How do they put plastics on something that's not there?
well, they have to reconstruct a lot, and then plastics will do a lot of the soft tissue stuff, and they rebuild what they can, and the skin grafting, all kinds. This is why he's still on the road to recovery. It's not going to rebuild everything. I think I had one, it was hard to see, but there was one CAT scan image that you could see after multiple surgeries that reconstructed. So they try to get them back to some level of normality, but yeah. So, not saying that this needed to happen with this patient, but it's a good thing to bring up. And we talked about it yesterday because you guys do have this tool in your toolbox. If things went south and you weren't able to get that endotracheal tube, this is definitely an option. This is a perfect scenario for this, that you could have busted this out if you needed it in a pinch. So your surgical airway, you all have surgical airway kits available to you. Again, make sure you're checking them, know what's in them. Every one can be different, no matter what department you've worked on. They've been set up. I've seen all kinds of different setups, so there's no right, wrong, and different. It just depends cost-wise how the department wants to go, what kind of equipment they're able to get their hands on, and what kind of procedure technique they want to use. So the one, I just threw this in here just to kind of remind that, hey, this is an option you guys have to you. And again, this is trauma training. So this is a video on EM Crit. It's a really good video. This patient's wide awake during this. Their jaw was wired shut from a previous injury, and they were having respiratory issues to where they had to cut the neck and do a surgical airway. This individual that does this stuff, and you'll see the little patch thing, he likes to say finger bougie scalpel is what he uses. Like I said, know your equipment, know what you have available to you, but quickly, without going completely into this, because we can do a full lecture on just this, the things I like to remember with it, no matter what equipment you have, is always mark your spot. So 3 o'clock in the morning in a ditch, trying to do this, hopefully that's what you remember. You start off marking your spot. Always find your landmarks first before you cut. When you're pretty secure knowing that that's your landmark you need to go for, start your cut. Remark your spot once you've cut the skin away, which is going to be your cricothyroid membrane. You now take your scalpel, puncture the cricothyroid membrane, open the cricothyroid membrane up. The spot is now marked with your scalpel. Making sure that you keep your arm that has whatever's in there leveraged on their neck, their head, their body, so that you move, flinch, somebody trips into you, you don't remove that area. You then take whatever dilating tool you have available to you. Sometimes it can be a cric hook, sometimes it can be hemostats. I think you guys have hemostats in yours. Insert those, open the area. You've now marked it with something else. Move it over, get your tube. Now you can mark it with your tube. Something I would recommend is if you can put bougies in with yours. Do you guys have bougies in yours?
Yes.
Awesome. Because a bougie, you place that, and that bad boy you can put a lot of real estate in there. So if you do flinch, move, something happens, something shifts, some of that can slip out and you haven't pulled the whole works. So he uses a bougie. You can place the bougie and then put your size 6 ET tube in there, or if you have a commercial device, he uses a commercial device. So just something I wanted to touch on.
Hey folks, after last year,
Always make sure your cuts are vertical. If you get into YouTube world and start looking at these, depending on what you see, sometimes surgeons, some docs will do horizontal cuts, but again, that's in a controlled setting. And somebody that may or may not have done this multiple times, I don't recommend it. Vertical cut. That way, if you're not exactly where you need to be, you can make it longer and get to what you need to. Also, give yourself a lot of space. I'm not saying fillet them from here to here, but give yourself enough space to work. So he's now punctured the cricothyroid membrane. That's not bleeding in the airway, that's blood around it, and as he's breathing, it's just splattering it out. See how he's marked his spot again after he's made that hole? He doesn't want to lose that.
Get your finger in place. Get your finger in there. That way you know it's going out like this.
See the person's eyes, he's wide awake. You've got the bougie placed. See, he's doing exactly what I said. He's keeping his arm and hand leveraged on some part of the body so that he doesn't joint that out.
What was the internal? I have it here. I have it here. But you don't need it right now.
Now that's a commercial device, so it's the size of a size 6 ET2. It just has the butterfly security pieces parts to it. Then they're going to hook them up to the bed. For us, of course, we bag them. Questions on that? Another thing you can mess with and try with your bougie, get your ET tube out. And if you want me to, I can show you later. Get your bougie out before this, or even if you're going to use it for difficult intubation, you can preload your bougie with an ET tube. Put your ET tube on the end that you're not going to be placing into the trachea. Take the piece that's sticking out, take it around and put it through the Murphy's eye there, and you now have the ET tube. And you can actually coil it to where it's a little tight so that you have more bougie hanging out, and you already now have your ET tube stuck on the end of your bougie. So you get the bougie where you want it. You can then secure it, pull your tube loose and just slide it on down. Instead of having to reach around, grab it, slide it over top, you can preload your bougie, and it's pretty cool technique. Yo.
Can I cut you off right here? This is
Yeah.
the last one, right?
Yeah, last one.
We just cut it short.
Yeah, that's cool.
Big double book training.
That's fine, I guess. Here, real quick. Pallet fell on person. Snapped his spine. Yeah. Distributive shock, blah, blah, blah. No, just kidding. T5, thoracic spinal cord injuries. If you have somebody that has an old injury or you're currently dealing with a new injury, that's what you're there for. You have to be concerned with distributive shock. Remember, container, dilation, vasodilation and constriction. These folks, that messaging system's busted, so you can tickle the vagal nerve and have their whole container open up, but now the messaging is not there to say, hey, constrict, blood flow is not there, there's not enough fluid. So things you're going to have to worry with these folks. This is kind of flip the script on internal hemorrhage. You're going to have to dump fluid into these people to make sure you're filling the container back up, because their body's not going to do it for them. It's not going to constrict and make the container smaller. Okay.
Thank you.
Somebody turn off the camera.
That's the AV club.